Welcome to our podcast series on shingles. The goal of this six-part series is to increase healthcare professionals' understanding and awareness of shingles, strive to reduce healthcare disparities and inequities, improve healthcare professionals' performance, and enhance quality of care for patients. During this first episode, we'll discuss the burden of shingles, focusing on incidence, risk factors, and complications. As we get started, I want to mention that this educational activity is supported by an independent medical education grant from GSK. Recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA. The AHA does not endorse any product or device. I'm Dr. Anthony Vieira, a family physician and chair of the Department of Family Medicine and Community Health at Duke University School of Medicine, and we have a fantastic panel lined up for you today. Let me turn it over to Dr. Wolf to introduce himself.
Hey, thanks so much, Anthony. I'm Cameron Wolf. I'm an infectious disease physician here at Duke. I mainly practice on adults in the adult sphere, and I look after transplant patients and HIV patients in particular. So we certainly run into shingles quite a bit and have to consider that in both our older and immunocompromised adults, as I'm sure we'll get into. I hold a joint appointment at our vaccine institute and try and do research trials in immunocompromised patients as well. Appreciate the introduction.
Hi, I'm Ken Schmader. I'm a professor of medicine here at the Duke University School of Medicine. I'm a geriatrician and clinical investigator. I do my research in herpes zoster and the development of zoster vaccines in older adults. I've had a clinic for zoster and post-herpetic neuralgia patients as well. And I've also worked with Dr. Wolf at the Duke Human Vaccine Institute.
Excellent. As I said, we have a fantastic panel. Thank you both for being part of it. Cam, this first question is for you, and we're going to start with the basics. It's a bit of a two-part question. What is zoster, which is also known as shingles, and what are the current incidence and prevalence rates in the US, particularly among older adults and immunocompromised populations?
Yeah, it's a great place to start, Anthony. I appreciate the question. So, to really get back to basics, shingles is the name that we prescribe to the chickenpox virus or varicella virus when it reemerges at some point later in life, and tends to do so on the skin, but as we'll get into, can be other places. So any one of us who've been at some point earlier in our life, as most Americans have, exposed and infected by chickenpox, carry that virus inside us. It latently incorporates itself typically into one of our dorsal root ganglion in our spinal cord, but occasionally into other nerve roots. The trigeminal ganglion is a common one, or occasionally even some of our autonomic ganglion nerve roots, but typically somewhere up and down the spine. And so as we get older, our risk of losing sort of control of keeping that virus dormant goes up. The older we get, or the more immunosuppressed we'll get, as we'll get into. And so we talk about shingles as the representation of when that virus wakes up, and typically presents on the skin or with other systemic features. It's common. About a third of Americans are estimated to run into shingles at some point in their life. So depending which way you look at it, 25% to a third of us. So a good number of us, and that percentage clearly goes up as we get older. There's a sense that it's been increasing a little bit for reasons which we could get into if you want, but a little more common of late than it has been in the past. But that trend is sort of a little skewed. It's more common in older adults and perhaps a little less common again as time has gone on in real young adults. There's a huge increase in immunosuppression. So in patients that I would look after, for example, who've had organ transplants or chemotherapy, depending on the type of immunosuppression and how you manage that risk of shingles can go up by sort of 10 to 100-fold. So it's a much more meaningful issue for immunosuppressed individuals. So, more common than I think we give it credit for would be the summary. A third of all adults, if they can run into shingles over the course of our lifetime, is that's a significant burden on healthcare. The clinical issue is it's painful. It's contagious. It can remain painful if treated poorly for weeks, months longer after the actual virus is sort of brought back under control by your immune system. And occasionally there are much more catastrophic issues with the eye or internally if it really gets out of control. So it's something to be avoided. Let's say that.
For sure. And one point that it might be interesting for folks to know, or the question of whether someone who's never had chickenpox can get shingles. That sometimes comes up from patients.
Yeah, it's a great question. I get that as well. I mean, for a start, I would say that for most older adults, we probably don't, whether or not you remember ever being exposed to chickenpox, you probably were. And I think there's a pretty small number of adults who are at risk of shingles who truly were never exposed as a kid. That's actually quite uncommon. Many of us still can carry the little skin blister, for example, when you knew you were infected, but actually lots of adults don't realize that they're infected and carry the virus. So in theory, if you were truly never exposed, you've not had a risk. These days, what happens very differently, of course, is we try and vaccinate our kids against varicella, and that poses sort of a different risk here that I'm happy to go into if you want later on.
Excellent. Thank you. Ken, this next question is for you. Have there been any shifts in shingles epidemiology over the past decade or so?
Yes, there has. As Dr. Wolf was mentioning, multiple studies have shown increasing age-adjusted incidence rates of zoster over the past few decades. And that's mostly in older adults and immunocompromised individuals. And that it's thought that the reason for that is population aging and the increase in immunocompromised patients. But interestingly, the CDC has noted that in recent years, and I mean since 2018 to 20, the incidence of zoster in the US has actually plateaued and it's starting to decline some, mostly in older adults. The flattening or reversal of this trend is thought to be driven largely by zoster vaccination. First with the live attenuated zoster vaccine and more recently by the recombinant zoster vaccine.
Do you think that there would be a point where zoster would be eliminated?
I hope so. That's a tall order. We have the tools to do that, by the way. If you vaccinate children early in life and you vaccinate older people late in life with the zoster vaccine, we can zero it out, but it requires getting vaccinated.
For sure. And Cam, building on that, how do demographic factors such as sex, age, or socioeconomic status affect the risk and presentation of shingles?
Yeah, it's a great question. You know, there's a gender difference. It's slightly more common in women. About 60-40 is the percentage that I see quoted. I'd be interested in what Ken thinks. I don't think we perfectly understand why that's the case. It's sort of postulated that the peak of that difference occurs around perimenopausal time and may have something to do with sort of hormonal changes and sort of the way that affects the immune system. But to be honest, I'm not sure that we perfectly understand that. It's it's clearly age related. So I talk about my patients being immunosuppressed because of meds that I'm giving them, but I think we need to think of aging as an immunosuppressive process in some ways. Our immune system sort of does become a bit forgetful, or we call it as immunosenescent as we get older, and we lose control of certain viruses under those conditions. So, the reasons, for example, we think about shingles vaccines, as Ken was talking about earlier, in older adults, is that we know that the rate of shingles absent vaccines really starts to take off in your 60s and then particularly beyond your 70s. That's really quite a substantial increase. And that's part of the natural process of aging. Now, what we're doing these days to everyone in the community is we're, for lots of people, augmenting that with different forms of immunosuppression and immunomodulation for all sorts of different conditions. And that simply increases that risk. I forgot to mention socioeconomic status. That's a really important thing to add in here is, socioeconomic status ties into so many other factors with our healthcare in general. Health access, health literacy, our understanding and ability to sort of keep up to date with vaccine schedules, your availability of having physicians at your beck and call, depending on where you live in the country, all of which I think at the end of the day probably increase risk for those in our community who are a little more health marginalized. And sort of is always this little tap on our shoulder to say, hey, like we can do that better, I think.
Mhm. Yeah, that's so important. We've touched on the start of the clinical manifestations already, but let's move on to talk more about that. Ken, what are the most common presenting symptoms of shingles and how do they typically evolve?
Well, the most common presenting symptoms of zoster are localized pain and or paresthesias and rash, I think as everyone well knows. The symptoms of zoster often begin with a prodrome of pain or paresthesias and they involve dermatome for a few days before the rash breaks out. And this is really a baffling time for patients and clinicians because it can imitate other painful conditions in older adults. I think we all have our favorite stories. Um, the patient who came into the ER, they thought it was a heart attack or biliary colic or a renal stone, and then the rash breaks out, and it turns out it's actually zoster. One clinical pearl I have for this is in this incipient zoster stage before the rash breaks out, patients will develop very sensitive skin in the affected dermatome, right in the affected dermatome, and then the rash may break out later. And the rash is classically unilateral. It's dermatomal, red, macular papular, usually develops vesicles, but not always. It tends to start crusting over in a week to 10 days and heal up in 2 to 4 weeks. And of course, while this is happening, many patients experience acute dermatomal pain or kinds of discomfort during this acute phase. And it can range anywhere from mild to severe. And unfortunately, for the people having really severe pain, it can markedly affect their quality of life. Burning, stabbing, it's miserable. The other thing to remember is this is an infection that's going on. So people feel lousy. They get fatigue, headache, malaise, and the like.
I think you've touched on this, but so rashes as well as symptoms such as pain and numbness are common presenting complaints. Cam, are there any other tips from you on how we differentiate shingles from other dermatologic or neuropathic conditions in primary care?
Yeah, it's a good one. And I think to Ken's point, sometimes those first few early days are really tricky because if, we all think of the rash, but including patients, but we often, I think, find it harder to see in those first few days. So, I completely agree with Ken. We all have our stories of missing shingles. Heck, the surgeons will tell you, of days gone by when the odd appendix comes out and then the rash appears. So I think that, it speaks to both the intensity of the pain, but also the challenge. I would say to build on the dermatomal context of this, which is important. It's always a healthy reminder as we go back in the heat of the moment to look at our dermatomal maps that we all learnt in med school that there's a lot of overlap in dermatomes. A single dermatomal impacted area can be quite wide, but that sort of adherence to the midline is pretty characteristic. I think the cadence of the illness is a big clue. So most other neuropathies would give you some inciting event, perhaps a trauma or a rib fracture, a new medicine that's causing some problems. The sort of the diabetic neuropathies that we see develop or drug-induced neuropathies take time. This is a reasonably sudden onset, sort of over the space of a day or two, things build up. There is often a stressful situation sometimes that can trigger it. So lots of people, in the same way that we get other herpes virus, like fever blisters, erupt under certain physiologic stress, that can be the time when shingles occurs too. So sometimes you'll get a little piece out of the history that might give you a clue. But I'll be honest, it's challenging to diagnose in that sort of pre-rash stage. I think the other thing that you sort of hinted at is that this is a neuropathy. It's not necessarily going to be terribly responsive to the sort of the typical causes of mechanical pain where we sometimes give, NSAIDs and opiates. They just have less impact here. Some of the odd syndromes are then also worth remembering. Like it's sort of more one of the feared episodes when shingles get in and around the eye. So you take with great caution the person who's presenting with sort of forehead or sometimes even nasal bridge symptoms of neuropathy, and they're starting to get that gritty eye or a little bit of vision change. Like that's the person I'm really concerned by. A low threshold to get some of our eye specialists involved in that setting.
Yeah, for sure. That's one of the scariest presentations. And Ken, adding to that, what other atypical presentations should we be aware of, especially in patients with comorbidities?
Yeah, well, atypical presentations are certainly more common in immunocompromised patients, but there are a number of them. Atypical rashes can occur in anybody, including older persons without immunocompromised. The rash may be limited just a small patch within the dermatome. Sometimes it doesn't read the textbook. It can be just maculopapular without the vesicles. Conversely, disseminated cutaneous disease, which is seen in immunocompromised patients, instead of a localized dermatomal eruption, what we see is a widespread rash with maybe crusting ulcerations and vesicles like varicella, but it's actually zoster. And this is often seen after transplant or chemotherapy. And by the way, this can go on for days and weeks without it being diagnosed because it doesn't look like zoster. You actually have to think about it and take a sample in the ulcer and the crust and find VZV DNA via PCR. The opposite happens. The virus VZV can reactivate without reaching the skin, without a rash, so-called zoster herpetae, just isolated dermatomal symptoms. That's tough to diagnose. You really need baseline, and serology is done 6 weeks later. The other atypical sensation piece I want to point out here is itching. I've had a number of patients and my colleagues who work in this area where all the person had was maddening itch. They'd want to scratch through their skin. And I learned that there is a complex neurosensory system dedicated just to processing itch, which involves peripheral nerves in the skin and the spinal cord that VCV can invade and cause problems. Other atypical manifestations include segmental weakness in the area of the dermatome. If you think about this, the dorsal root ganglia is involved in the sensory part, but the virus can sometimes go down to the ventral root and cause motor weakness in the dermatome. And we know about facial palsy and ear vesicles with Ramsay-Hunt syndrome. Also Bell's palsy, another clinical pearl there is if someone has a Bell's palsy that's painful in the dermatome, it's zoster. And there are other neurological complications we'll probably talk about as we go along.
It's a sneaky virus, isn't it?
It is.
All right. We've talked some about comorbidities. Let's shift now to risk factors. Cam, which patient populations are at highest risk for shingles, and how do you assess risk in routine practice?
Yeah, good question, Anthony. I mean, I think the first thing that we've talked about is a direct proportionality to age. And I guess I shouldn't say direct as in linear. It's sort of more of a significant uptick as we get into our 60s, 70s, and beyond. So age is an independent risk factor of all else. Beyond that, whether you've had a shingles vaccine is now an independent risk factor. We'll get into some of the details there, I'm sure. Beyond that, I think anything that would be functionally immunosuppressive, and that's clearly these days a complex question. We all think of our prednisone patients as being immunosuppressed, but I would say in our defense, our rheumatology, dermatology, allergy, immunology colleagues are continuing to come up with some new and novel ways of attempting immunosuppression and finding different arms of our immune system to immunosuppress. And I would say each of those has a different way of augmenting risk for shingles, some more so than others. Generally speaking, I think of this as a sort of a T-cell controlled and mediated condition. So certainly many of our solid organ transplant patients have a meaningful risk of immunosuppression. For them, the risk is proportional to the drug doses. So early after transplant, first sort of 3 to 6 months in particular, they tend to be on more immunosuppression. Their body's getting used to the transplant. Therefore, their risk of any latent virus, including shingles waking up, is higher. Chemotherapy, you view through the lens of what's the individual drug that you're being given. So, how long does it last? How long is the effect on the on the immune system? Some of the conditions that we are treating are immunosuppressive in themselves. So if you present with a leukemia, that is a direct immunosuppressive disease. Same with if you present with advancing HIV. It was one of the old teaching points for clinicians when we saw more HIV in the past, and we still do sometimes, that a new presentation of shingles in someone who really didn't seem the right age demographic for it, you should put your thinking cap on and say, hang on, like, what is there something unusual about this person's immunosuppression state that this would be presenting now? Um, and you know that so that I don't want to sort of paint it as a you're at risk or you're not, because I think these are really stages of gray. It's clearly proportional to age. It's proportional to the type of immunosuppression that you're getting either from our medicine or from your illness. And they're sort of continual measures that ebb and flow as we age.
I know we've talked a little bit or a bit about the neuropathy, the postherpetic neuralgia. Let's get into that some more. Ken, what are the most frequent complications among patients with shingles?
Well, you alluded to the most frequent complication of zoster, and by far and away the most feared complication is chronic pain or postoperative neuralgia. And that risk increases with increasing age and also pain severity at the beginning of the episode. I want to point out that postoperative neuralgia or PHN patients experience three types of pains. Not all, but one is people may experience sort of constant pain, this constant burning, aching, throbbing that doesn't go away. And they may experience intermittent lightning, lancinating like pains, sudden stabbing or shooting. And if that's not bad enough, a lot of patients have stimulus evoked pain, allodynia, just the lightest touch of the skin. Can cause pain. And when you have all three of these together, you can understand it has a huge impact on quality of life and functioning. We talked about ocular complications a little bit too. I think that's a really important thing in ophthalmic zoster. Visual impairment, keratitis, uveitis, sometimes acute retinal necrosis. I think we talked about a lot of neurological complications, but I also wanted to point out, particularly since this is an AHA presentation, that zoster is linked to an increased risk of stroke and myocardial infarction months to several years after an episode of zoster. It's thought to be related to a VZV-induced vasculopathy where there's inflammation and damage to blood vessels, but interesting observation in observational studies.
Yeah, for all of us who have seen patients with postherpetic neuralgia and the painful and the way you described it is just it's so awful. And so the more we can do to prevent it, the better. Um, Cam, can you share insights on any more rare but serious complications, elaborating on the zoster ophthalmicus and or disseminated zoster?
Yeah, for sure. I want to jump on the back of what Ken said just a minute ago, though, because his description of allodynia, that sort of pain on even light touch, just rang so many bells to me in my clinical experience. Like, you know, that's there when the patient's really reluctant for you to even brush up against the part of their skin that's affected. And it keeps them up at night time. They can't get the bed sheets comfortable. Like, they struggle to put on pants or a shirt, depending on where it is. It's disabling in the literal word of the meaning of that word. So it's a really good description, Ken, of the different types of pain and how we need to think about it. Sorry, Anthony, I digressed there a little bit. You mentioned sort of other complications. I think we should lean into the ophthalmic ones because I think they're real. Um, the propensity for ophthalmic zoster, if left unchecked, to cause visual loss is real. It's something where I think really a good eye specialist needs to ideally be involved, is what we would say in someone who you're nervous. It's one thing to be involving the top of the temporal scalp. It's another thing to start hitting that little perilacrimal piece of skin there that then could then there's a separate sub branch that then wraps onto the front of the cornea. And we always sort of teach our members, fellows, to look at that little piece of skin on the inside of the nasal bridge. And if you're starting to be involved there, you've got to really watch out for the cornea and the eye. Some of the unusual ones are, you hinted briefly, I think, Ken, at retinal necrosis. So actually involvement in the back of the eye. We have certainly seen that from time to time. It's difficult to diagnose because it may not come with the rest of the skin findings of shingles, but a good ophthalmologist will be able to look at that and say, hey, look, I think this is really a herpes virus process going on the back of the eye. You can figure that out by retinal sampling, but as you might imagine, that also needs highly specialized care to be able to do that. That becomes less common if you have less varicella wake up, put simply. Some of the other ones, complications that we sort of dread are, again, related to dissemination to places outside of the skin. So Occasionally autonomic ganglia can be involved as the latent place where shingles reside, varicella resides. So, does that affect gut function, for example? Can that affect the central nervous system, the spinal cord? And occasionally we'll see varicella affecting the CNS along that spectrum of meningoencephalitis in ways that can be complicated and at times life-threatening. Truly disseminated multidermatomal zoster is certainly something that we see still. I would agree with Ken's point earlier that it can be harder to pick because, we're sort of trained to think about dermatomes with shingles. And so if you see sort of multifocal blistering lesions, there's not a lot of things that can actually do that. As a blistering rash, it should be on the differential for that. Again, if, the more likely you are to have internal visceral involvement is proportional to whether you see multidermatomal involvement. So the issue to me with someone who presents disseminated with multiple regions of skin affected is not that the skin's the problem, although it certainly can get secondarily infected. It certainly can be painful. The risk is that increases the likelihood that some internal organs, brain, kidney, heart, lungs, are also affected. And that's the sort of the greater threat to diagnose that earlier and get that person on higher dosed antivirals. Ken, do you see a lot of shingles as well? What sort of other syndromes have we not talked about here?
I think the only follow-up point I'm making that I think you did also mention is that these unusual syndromes, the meningitis, encephalitis, transverse myelitis, any other organ involvement, pneumonitis, hepatitis, can certainly occur from VZV without any rash whatsoever in an immunocompromised host. I can't recall seeing that in an immunocompetent, quote unquote, older adult, but it seems where I've seen that before has been mostly in transplant recipients, particularly bone marrow transplant. I mean, what do you think, Cam?
Yeah, no, I think that's a fair point. The more likely disseminated patients or internal only patients are, I'm sure, are more heavily immunosuppressed. Like, I feel like we see the occasional case of transverse myelitis where we'll pick up varicella on spinal fluid, and it's sometimes difficult to know, is that true attributable cause of the disease, or is that the innocent bystander that's reactivating when something else is going on? They can be hard to diagnose, frankly, and need a lot of specialist care. But I think you're right that any internal organ inflammation, hepatitis, pneumonitis, carditis, myelitis, much more common in transplanted or actively immunosuppressed people.
Of the ones that we've talked about so far, it seems for the primary care clinicians, they're most likely to see the ophthalmic involvement. And a related question then for folks like myself is, how quickly do I need to get that patient into the ophthalmologist?
I'm not sure if either of us should tackle this, or maybe both of us. I mean,
We'll start with you, Cam.
I would say, always good luck finding an ophthalmologist with ready availability. Clearly it depends on where you are in the country. We're fortunate here to have a great eye center on campus. But that it can be tricky. So, no one would fault you if you were nervous about eye involvement and you started the person on antivirals while you tried to move down that line. I do think if there's any eye involvement, if the person's already talking about vision change, blurriness, sort of a grittiness across the cornea, and you don't have a ophthalmologist on dial, I think that's a medical emergency enough to go and see an emergency room. I'll be totally honest. Mm-hmm. We don't see that often, but when it's vision threatening to me, that's an ER trip. I don't see anyone arguing with that. What do you think, Ken?
Yeah, I think the earlier the better. The ophthalmologist can see things in the back of the eye that we can't, whether there's some other involvement. And I love the idea about antiviral cover, but they use other medications to reduce inflammation to help prevent visual impairment too.
Yeah, that's great. Let's conclude with the one that we've alluded to, that is the dreaded one, the postherpetic neuralgia. And what's the most effective way to prevent this painful complication? Ken, we'll start with you.
Well, the most effective way to prevent postherpetic neuralgia is not to get zoster in the first place, right? The most effective way to do that is by the use of the recombinant zoster vaccine. Our audience may be familiar that the phase 3 randomized controlled trials of recombinant zoster vaccine showed remarkable vaccine efficacy, 97% in 50 to 70-year-olds, about 90% in people 70 and older during the 3-year duration of the trial. They may not be familiar that there's a long-term follow-up study that's been going on. It's up to 11 years now in the trial participants, and that's showing vaccine efficacy of 82% in people over the age of 50, 73% over 70. So the effect has been quite durable over time. And in doing that, it also reduces PHN, of course, and even in people getting zoster, the likelihood of going on to PHN is much less in vaccinated individuals. The CDC has done post-marketing observational studies, one in the Vaccine Safety Data Link database and also in Medicare. And there, the overall effectiveness has been less. Again, these are vaccine effectiveness, not efficacy studies, but it's been around 70 to 76% over a 4-year period. So still pretty good effectiveness, particularly for vaccines in older adults. And of course, the recombinant zoster vaccine is recommended for people 19 and older who are immunocompromised, and it is not quite as effective as in immunocompetent persons, but it's still pretty darn good. There is a true randomized placebo-controlled trial in stem cell transplant recipients, and the vaccine efficacy there was 68%, which is pretty special. I also want to point out that for the patients who do develop zoster, we know that pain severity is a strong predictor of post-diabetic neuralgia. So effective pain management early on is really important. And there's 2 prongs to that. One is early antiviral therapy does reduce the acute pain, and all the antiviral therapy trials did show a reduction in acute pain when it was used early. And also careful analgesic pain management is really important in these patients.
I mean, there's some great statistics there, Ken. Like you're talking about a bone marrow transplant patient, the most immunosuppressed people we have, where you've got a 2 out of 3 reduction in shingles case burden. I mean, that's profound.
Mm-hmm.
Or 19 out of 20 older adults will not get shingles as a result of that injection, like in the original parts of those trials. I mean, that there's statistics that really should speak for themselves. I mean, they're the numbers that I tell patients to go like, this is why this is relevant. Yeah. Yeah, they're durable numbers, which is also important.
Absolutely. It's a powerful intervention to prevent a horrible complication.
Yeah.
Anything we haven't covered that either of you want to close with?
I sometimes go, I hope this is not off-label, but I will say that I also think real carefully about people in whom I know are going to become immunosuppressed, in terms of the way I think about discussions of shingles with them. Like I see a lot of people in clinic who, are either, early 50s, for example, but heading towards needing dialysis or heading towards needing transplant, or we're picking up that early sign that maybe there's chemotherapy in their future, or that their diabetes is coming out of hand a little bit, and that they're functionally a bit more immunosuppressed than I would like them to be. And I use that as an opportunity to lean in to say, you're going to respond better to a vaccine that I give you now, both in terms of the magnitude and the durability of how your immune system responds. If I give that to you now, before you face this impending immunosuppression, like I will give you a lasting benefit that is much better than waiting. And I think you can use that argument as a really important reason. And that's true not just for shingles. Heck, that's true for Tdap, pneumovax, flu vaccines, COVID. Like that's true for any vaccine. But like particularly here, when you're talking about a vaccine that has many, many, many years worth of benefit, lean into the fact that you'd rather give it ahead of the immunosuppression if you know that it's coming.
That's an excellent point. Ken, you get the last word.
Yeah, I'd like to talk about acute zoster pain management a little bit, because I've seen a lot of suboptimal management there, and it's particularly important for primary care physicians. Patient will come into the emergency room or some other location. Yeah, you've got zoster, here's some oxycodone or an NSAID, and then they don't really get good follow-up, and no one's really managing it very well. So it requires the same principles as any good pain management, following up with standardized pain scales, scheduled analgesics, adjusting dosing according to the needs of the patient. And their treatment's going to be contingent on what their comorbidities are, current medicines, pain intensity. Anthony, this is an art to do this right, right? And it's the people with severe pain that are difficult. They will probably need, first off, an opioid like oxycodone, but some of those people, the oxycodone doesn't work, and they need follow-up. And those individuals we may consider therapies like gabapentin or pregabalin. And it turns out that anesthetic nerve blocks do help people with acute zoster pain, and they're often forgotten. So I just want to put a plug in for that too.
Absolutely. Well, this was a great discussion today. I want to thank you both for sharing your expertise with us. And thanks also to the American Heart Association for allowing us to cover the introduction to this important topic. This podcast and future episodes will be available through major podcast platforms. And to claim credit, visit learn.heart.org. Thanks for being with us.